I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Greetings and welcome to another edition of the PRS Monthly Journal Club podcast for October 2018. I'm Nicole Phillips, Resident Ambassador from the Harvard Plastic Surgery Program, and I am joined today as always by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. This month, we are excited to have Dr. Gordon Lee as our guest moderator. Dr. Lee is Professor of Plastic Surgery at Stanford University, where he is also the Residency Program Director for Plastic Surgery, Director of Microsurgery, and Associate Chief for Clinical Affairs. Dr. Lee, thank you so much for joining us today.
Well, thank you for having me.
Before we begin our discussion, I just wanted to give a quick reminder to our listeners that this article, along with every PRS Journal Club article, is available for free online on the PRS website. There, you will find selected classic article pairings, as well as related video content. So if you're curious to learn more about the topics we discussed today, please take a look at this section online. The article we will be discussing next is entitled, "The Functional Influence of Breast Implant Outer Shell Morphology on Bacterial Attachment and Growth" by Jones et al., with Anand Diva as the senior author. The authors of the study are based in institutions in both the United States and Australia. I mention the geography specifically because it played a large role in my selection of this article. I recently began an aesthetic fellowship in Gold Coast, Australia, and one of the first differences I noted upon my arrival here was the more frequent use of anatomic textured implants for cosmetic breast augmentation. Given the recent intense focus on ALCL, both in the popular media as well as within our plastic surgery societies, I was interested to learn more about the research behind implant selection. This study builds off of previous studies from the Joint Australia-New Zealand Task Force, examining the incidence of ALCL within this population and the risk factors associated with the development and progression of the disease. In these previously published studies, high surface area textured implants were linked with a higher incidence of ALCL within this patient population, leading the authors to hypothesize that greater surface areas promote higher levels of bacterial biofilm, resulting in a significant increase in lymphocyte activation. In genetically susceptible hosts, this increased immune activation may, over time, result in the transformation of T cells into breast implant-associated ALCL. While research on ALCL risk factors, pathogenesis, and treatment is still ongoing, the suggested pathway of increased bacterial load resulting in transformative immune processes has resulted in ongoing focus on how to minimize risk for our patients. This has resulted in technique papers, such as the featured paired article from Adams et al. Describing the 14-point technique for minimization of bacterial contamination during implant placement. It has also resulted in the current study, which is focused on the question of breast implant shell morphology and its relationship to bacterial burden. The authors of this study took a very scientific approach to examining the outer shell morphology of a variety of breast implants from different manufacturers. 11 implant surface types were subjected to testing. Imaging of the implant surfaces was performed using scanning electron microscopy and micro-CT scans. Using the results obtained from these imaging modalities, the 3D to 2D surface area ratio was calculated, as was the surface roughness. Both of these values were then normalized to smooth implants for comparison. The implants were grouped into 4 categories based on the 3D to 2D surface area ratio: high, intermediate, low, and minimal. It was found that these categories generally corresponded with implant shell manufacturing processes. The implants were again divided into those same 4 categories: high, intermediate, low, and minimal, for surface area roughness. In vitro bacterial attachment assays were then performed on the implants with 4 bacterial pathogens: Staph epidermidis, Staph aureus, Pseudomonas, and Ralstonia piquetti. Implant samples were examined at 2, 6, and 24 hours to study the relationship between surface area, surface roughness, and bacterial growth. This analysis demonstrated a significant linear correlation between bacterial attachment and growth as the 3D to 2D surface area ratio increased. Based on these findings, the authors propose a 4-tiered surface categorization of breast implants centered on combining outer shell surface area with surface roughness. They then suggest that the surface grade be combined with a nomenclature to define fill, surface, shape, and size of the implant as a more refined means of examining different breast implant options. The question of implant selection is really at the heart of the study, and so I'd like to open the discussion here and begin by asking Dr. Lee, Do the advantages of using textured implants outweigh the risks, in your opinion? And does a more refined classification system, such as the one proposed by these authors, help us to quantify those risks more appropriately?
Those are great questions. I think the paper raises some very interesting questions about the issue of textured implants. As the paper mentions, most of the studies that have looked at large patient populations with breast implants often failed to fully characterize the type of implant and the degree of capsular contracture, etc. So basically the article points out, which I also agree with, that it's not really clear that texturing of implants has a significant advantage. I believe they mentioned that in some of the primary augmentations, particularly for those that are subglandular, there may be an advantage to texturing for early capsular contracture. But there seems to be, again, a lack of strong evidence that texturing is helpful in other types of clinical settings. So I think that the issue of texturing with implants is certainly questionable in terms of its overall benefit, and the fact that it's been associated with ALCL is certainly concerning. So I myself tend to gravitate towards the smooth round implants or smooth implants because of the concern for ALCL. Many of my patients, all of my patients are informed of the risk of ALCL as part of our informed consent process. And as a result of that, I believe that the majority of my patients are choosing smooth implants for that reason. So to answer your question, it's not clear that the advantages of texturing is in fact beneficial and worth the risk of the ALCL. Your second question was the classification system and whether or not that has additional value. First of all, I think this is a great paper that really looks into that and does a very deep dive on different kinds of texturing and really further characterizes it at a electron microscopy level, the degree of texturing and surface area, etc. So I think it's a really great paper to talk about. I think that it needs some clinical correlation, though. Clearly, it's shown the higher surface area can definitely lead to higher bacterial growth, etc. But what's still, in my mind, lacking is the direct correlation of how this translates to the risk of ALCL. And I think that piece for me is still missing.
Yeah, absolutely. And one of the things that I've been impressed by here in Australia is, there's this very active Australian breast device registry in which we send, all of the information about each case to the registry, and they're really being very proactive in gathering information. I think the question of ALCL has driven that in large part, so I'm very curious to see the outcomes from that data that's being collected. Ira, what were your thoughts on this paper?
I thought this was a very good paper and, again, very timely, as ALCL is such a hot topic. And there's a tremendous amount of research aimed at determining the etiology and the risk factors, and certainly being exposed to a textured implant is a key risk factor. And as you mentioned, Nikki, last year, this is a follow-up to Dr. Diva's paper in PRS about their data in Australia and New Zealand. And in that paper, they showed that the risk of developing ALCL was significantly higher for certain textures such as biocell and Silamed polyurethane compared to Siltex texture. So certainly how the texturing process occurs and how textured an implant be certainly appears to be a correlative risk factor. Their reclassification they propose may have an impact on how we think about the risk of ALCL to specific implant shells. I guess my question to you, Dr. Lee, is given this classification system that they propose, would this change in how you counsel patients about their risk of ALCL? And when you talk to patients about consent if you were to use a textured implant, you mentioned that they're shying away from textured implants and they're going to be opting for smooth implants. Do you find patients, particularly the reconstructive patients, just sort of have breast cancer and the idea of possibly introducing a foreign body that may cause additional malignancy probably, I would assume, would make them very fearful? What's your counseling process, and would you think this classification system would change how you counsel these patients?
Those are great questions. There's no question about specifically the reconstructive patients, the patients who have known breast cancer or are breast cancer gene carriers. These patient populations are very much in tune with cancer and malignancy. And I think for many of those patients, when counseling them regarding the issue of texturing and the potential risk of ALCL, they are very much concerned about the possibility of a second malignancy. I do counsel patients regarding ALCL. I do quote the Anandiva papers that have talked about the potential risk and incidence of ALCL being anywhere from 1 in possibly 30,000 to 50,000. And it seems like, again, there's still a lot of information we don't know. So that's just obviously an estimation. It could obviously be higher or lower. And so for that reason, because there's lots of information that we don't know, I think that patients are certainly fearful. And they also ask the questions, as most of our patients and plastic surgeons have asked, well, what is the true benefit of the texturing? And so if there is a choice to utilize a smooth implant and therefore eliminate the entire discussion of texturing, then patients will often choose that form of implant. I think going back to the benefit of texturing, for those plastic surgeons who are utilizing anatomic shaped implants, I think that, in my mind, is one of the clear benefits of the texturing, is the tissue adherence to an anatomic implant so that those patients don't suffer from malrotation and malposition of the implants. But if you're using a round implant, then again, I think it's unclear whether or not texturing has a true benefit in that situation.
Those are some great points. I personally, in my training, have not used texture implants very much at all. And I think the indications, as you mentioned, are, like you said, for anatomic shaped. And I think that, given the risk of ALCL, the global trend, or at least the national trend, tends for people to be really limiting their use of it unless truly necessary. Francesco, what are some of your thoughts about this paper?
I thought it was a very well conducted study, and I thoroughly enjoyed reading it. I would have to agree with one of Dr. Lee's statements about the clinical correlation, both to ALCL and capsular contracture, because I think that's really going to be the selling point and what will make surgeons change their practice potentially. You mentioned, Dr. Lee, that you now use less texture implants. And, Ira, you also mentioned that in your practice you have rarely used texture implants. I'm noticing here in Pittsburgh, a lot of our breast surgeons are moving away from texture implants, and specifically because of the ALCL issue. So my question to you, Dr. Lee, is, do you think that texture implants will leave the market in the future?
I think based upon the growing body of evidence, there is clearly concerns with texturing, and this paper does a great job of showing that with increased roughness and surface area, there is a greater propensity for bacterial growth, and therefore concerns for contracture as well as ALCL. So I think that if I was to predict, I would imagine that the process for texturing would potentially be modified by some of the manufacturers, particularly those who are in the high end of surface area and texturing because of this issue. I think that what we're going to probably see is some sweet spot, if you will, where the degree of texturing allows for just enough ingrowth to allow for tissue adherence and avoid issues like malposition and rotation, etc., but not be so high surface area that you are on the far end of the spectrum that potentially could lead to more bacterial growth, more contractures, and by correlation, higher risk and incidence of ALCL. So I think that manufacturers are going to be re-examining the texturing process and looking for some sweet spot.
Thanks, Dr. Lee. We had the pleasure of having Dr. Adams as a visiting professor, and I think one thing that I noticed to different surgeons is that, and reading about ALCL, is that also there are different hypotheses of why ALCLs occur, specifically with textured implants. And I know that Dr. Adams is a strong advocate for being an infectious cause, but perhaps it might be a non-infectious cause. So I don't know, it will be very interesting to see how things evolve through the years and as our understanding of ALCL evolves. Thank you so much again.
And I think this conversation has been great because it's really highlighted the reason why I selected this article. Like Francesco and Ira, I had limited exposure to textured implants in residency. We used anatomic textured implants occasionally for reconstructive cases, but really not as much for cosmetic cases. And here in Australia, we use pretty much exclusively anatomic textured or even round textured. And these are next generation, again, micro or nano textured implants based on the, the data that's been coming out from these groups. And so it was just very interesting to me to see the difference between the two sort of cultural climates. And obviously there's a large focus on research and examining causes and pathogenesis of ALCL, in the groups here. So obviously they're very aware of it and still choosing to use these implants with texture. So I think Dr. Lee's point about, that this is really mostly going to affect manufacturing processes moving forward, I think is probably correct, but I'm very curious to see how it unfolds in the future, and I think this was a great conversation. I'd really like to thank Dr. Lee and my co-resident ambassadors for this interesting discussion. And before we go, I'd like to remind our listeners to tune into the other two October 2018 PRS Journal Club podcasts. If you like what you hear, please share us with your colleagues and rate us in the Apple iTunes Store. And be sure to visit our PRS Facebook page, where you can follow the journal and join us for our monthly Facebook Journal Club. There you can interact with each month's featured authors in real time. Thank you again, Dr. Lee, for joining us today.
Well, thank you for having me.